Okay, so this is acute limb ischemia. It's video number 2. A 51-year-old man presents to A&E complaining of sudden onset right leg pain and weakness while out walking his dog. How would you assess him? So I would take a history. First of all, duration when these symptoms started, then root out the risk factor. I know he is a male. Ask about his heart problems, his previous history of claudication, previous history of any vascular surgery interventions, any history of stroke, and any other medical condition, diabetes, hypercholesterolemia, what medicine he is on, social history of smoking and alcoholic drinks. And then examine the patient. First of all, rule out the atrial fibrillation by doing the pulse is regular, and do ECG, and then we will rule out the abdominal aortic aneurysm. Sometimes these patients have associated aneurysms, and then check for the peripheral pulses using a handheld Doppler, and also check the motor and sensory function of the heart. Take the blood for FBC, unit clotting, and full coagulation screen prior to the commencing anticoagulation. Can you briefly tell the anatomy of the blood flow to the leg? So common femoral artery, and then divided into profunda femoris artery and superficial femoral artery, and SFA in the public fossa divided into the antitibial artery and tibial trunk. And now next question, he is in sinus rhythm. He has palpable right femoral pulse but no distal pulse in the right leg. Left leg pulse is normal. He has reduced sensation but normal movement. There is no significant past medical or family history. What is your diagnosis and how would you proceed? This patient has acutely ischemic right leg which appears viable. It's Rutherford grade 1. So differential diagnosis include the embolism from the cardiac arrhythmia, mural thrombosis, vegetation, cardiac tumor, proximal aneurysm, popliteal aneurysm, thrombosis, and arterial dissection. I would treat with IV heparin to restrict thrombus propagation and further emboli, and give supplementary oxygen and fluid, and replace the bed head up and foot of the bed down to improve blood to the foot with gravity. After book him for an urgent embolectomy with potential fasciotomy. The embolectomy may require a popliteal approach. So explain briefly how you will do the embolectomy. Longitudinal incision in the groin, centered over the CFA, control of CFA, SFA, PFA. Transverse aortotomy can be done but requires the patch. Transverse aortotomy in the CFA just above the origin of profunda femoris artery. If doing longitudinal aortotomy, then needs the venous patch. Fogarty catheter 4 or 5, first proximal trawl, and then 3-4 French for distal trawl 3 times each way until good inflow and back bleeding. Remember to check angiogram post-op if necessary, and if foot does not pink up. What is the problem of doing just femoral approach? Most likely the anterior tibial artery clots will be missed. May need to explore the popliteal to do all the 3 vessels. Hence pre-op imaging may be useful to make a decision. How would you carry out the fasciotomies? So 2 finger breadths below fibular head, lateral to the right border, 2 finger breadths above the lateral malleolus, and medially 2 finger breadths below the head of fibula and lateral to the medial border, medial to the middle border, and 2 finger breadths above the medial malleolus, and look after the great saphenous vein and sural nerve. When would you consider thrombolysis for an acutely ischemic limb? Catheter-directed intra-arterial thrombolysis would be considered in patient with acute limb ischemia whether the limb is not immediately threatened and the patient has no contraindication of the thrombolysis. It is particularly used in the patient with the occluded prosthetic graft. How would your management differ for an 88-year-old frail who presents with 6 hours history of cold, mottled left leg and atrial fibrillation? Elderly patient with underlying cardiac pathology presenting with acute limb ischemia have high morbidity mortality rate. The patient require cautious orientation and anticoagulation mere procedure, and any procedure may need to be carried out under local anesthesia. And with advanced ischemia, tissue damage, primary amputation or palliation will be the option for these patients. Thank you.